Welcome to this New Year's first session in Global Health. It's delight actually to welcome back to the Medical Ethics Program Father John Paris, who will be visiting with us in the winter and spring quarter. John, we're delighted that you chose us over Stanford this year. Great honor.
My God, he's going to be here for 6 months.
Yep. Our speaker today is Dr. Habibul Hassan, who is a professor in the Department of Health Studies and directs the Center for Cancer Epidemiology and Prevention. Dr. Hassan's medical degree is from Dhaka University, yes, and then his master's degree in public health is from the University of Western Australia. His postdoctoral training in cancer epidemiology was done in the States at Columbia. His research interests have been on studying the relationship between environmental and genomic factors in cancer and other diseases. His ongoing work, and you'll hear part of it today, about the carcinogenic effects of arsenic exposure has been supported by NIH-funded research projects. His work has taken him to Bangladesh, where he's examined some of these issues. Today's topic, as you can see on the board, is arsenic contamination of drinking water in South Asia, consequences and solution of a mass poisoning event. Habibul, thank you so much for coming to the program. Thank you.
Thank you. Thanks, Mark, for the excellent introduction, and thanks for asking me to speak to this forum. As Mark said, I'm an epidemiologist. I do work in cancer and environment, and almost half of my work actually is related to global health. And the way I define is that half of the work actually is taking place investigating the health and welfare of populations of outside the United States. Other half of my work relates to breast cancer and genetics, mostly related. And also, some of them are actually global health because some of those work involved population outside U.S. also. But my talk today is on arsenic in drinking water problem in South Asia, and I will talk a little bit about its, how it happened, what's the impact on health, and what are the approaches to solve this problem, at least from the health perspective to some extent. In 1977, United Nations conference claimed that all people, they have the right to have access to drinking water in quantities and of a quality equal to their basic needs. Obviously, this is a broader concept, and there are many ethical issues related to this point. But my talk, I'm not going to cover all these broader issues, but it will talk about more of a specific problem, as I mentioned. And what I will do, I will give a little quick, broad outline about the drinking water problem globally, and then I will talk about this specific problem I mentioned, this issue of arsenic in drinking water in South Asia, covering its causes, consequences, and some of the mitigation aspects, a little bit of ethical implications also, and then I will mention briefly what direction we are moving on that topic. Okay. So if we look at where actually the water are coming from that we drink, and obviously while we are surrounded by water everywhere, only about 3%, as you can see on the top left bar, can be actually tapped for drinking, and only 1% of that, if you look at right, are actually drinkable and commonly used. So, and this is that part which shows here is actually the 1% of this 3% that mostly is in the reservoir and the lakes, what most of this country and some of the other countries actually tap for drinking purposes. this part is drinkable, but this majority is not in liquid form, and this part is drinkable, but they are mixed in the different aquifer of underground, but they can be accessed, and that's one of the point I will relate to my talk today, as you can see. So, how important is this drinking water problem? Globally, 1 billion people, about 1 in 6, are affected by this problem. That leads to about 3 million deaths every year, which is equivalent to about, say, if you can imagine 30 planes are crashing every single day, that would be the amount of deaths that are happening in a year. And if almost half of all hospital beds in the world are occupied, that's fine, are occupied by diseases that are related to the drinking water problems. Okay? Obviously, this problem is not uniform. Some parts of the world it's much more, and some individuals are more, affected than others. The couple of areas in South Asia and Sub-Saharan Africa, that's where the problem is actually up until now has been maximum, and only 30% of the population in that part of the world had access to good, safe drinking water. And even in that area, women and children are more affected than others. Just to get a comparison, that we, on average, about per capita water use is about 2.6 gallon in the developing world, as opposed to, say, we use here in the US about 130 gallon, just to get a sense of where we are. Fortunately, though, this situation have been improving rapidly. That's the good news, and for various reasons. And as you can see, over the last 30 years, only about 30% of population in the developing world had access to safe water, and now means about 2000. This data that shows that about 80% of this coverage has risen, which is a significant improvement. And one of the goals for one of the Millennium Development Goal is to raise this up to 90% by 2015. So the problem of drinking water has been, improving rapidly, and the stuff that I will talk today is actually partly relates to this improvement, unfortunately. And in South Asia, in West Bengal, India, and Bangladesh, and some of the other countries in that region also, actually this has been their source of drinking water before 1970s. Okay, typically this is as a pond. And like surface water, as I mentioned, people used to drink water from there. And of course, this water was a source of many microbial organisms. As a consequence, waterborne illnesses has been a major problem in those countries. Infant mortality was more than 120 per 1,000 live birth in that part of the world. So that created a major intervention by international community as well as the governments in that area. They made some nationwide campaigns and successfully, over the next 20, 30 years, moved almost 90% of these population to shift their source of drinking water from here to here, which is essentially a hand-pumped well, and that digs underground and gets access to groundwater from different aquifer, and that is pathogen-free. So, as a success of that, infant mortality rate in that part of the world in the last 20 years became half. The other waterborne illnesses also are going down. So it's a dramatic success for that change, shifting of water from this surface water to underground water in that part of the world. But unfortunately, that also has brought the problem at least in that part of the world. Now we are, in at least only 10 years ago, there was an epidemic in that part of the world of these arsenic-related health problems. Until then, only then after 20, 30 years of exposure, they discovered that these groundwater that people have been drinking for the last 30 years have had very high level of arsenic, which is one of the potent toxic and carcinogen I'm going to mention in a second. Please stop me, by the way, if you have any questions, or clarification as I go along. So the arsenic contamination of groundwater, actually, it's turned out to be, it's not only in that South Asian part. It's actually a global problem. And as you can see, some of this part of the world, this colored part in different parts of the world, including North America, South America, even Africa, Europe, and these South Asian regions. This arsenic in drinking water is a problem. Okay, and I will particularly mention about this region. This country here is is Chile and Argentina. That's where the problem has also been in a severe 20, 30 years ago, and they now solved the problem. But we know a lot of these health effects of arsenic from studies conducted here and another country here. You can see Taiwan here. That country has also had a major problem 20, 30 years ago, and now they have solved that problem. But we also know a lot of the signs coming from the studies done here and here. I'm going to mention that in a second. And the problem here is tiny segment, this encroaching western part of India and the Bangladesh adjoining. That's where the problem that I'm talking about now was detected recently. But because of, even in that tiny area, this small thing, but this dark color shows the density of the population. And because of the high density, even this tiny segment, you can see almost more than half of the almost 150 to 200 million people in the world who have been affected by arsenic in drinking water. Almost half of them, depending on what limit we consider, this is the national limit in that part of the India and Bangladesh is 50 microgram per liter. That is acceptable. And WHO recommends this to be 10 microgram per liter. But you can see that up to 80 million people right here, which is about 40% of the total population in that region, they are now drinking this arsenic contaminated water. And this actually has been designated by WHO as, I don't know whether that's exactly true, but they have designated this as the largest mass poisoning in human history. And I cannot think of it's a bigger one than that, but this is, maybe this is the largest one. That's what WHO has designated the problem. So how and when did this arsenic in this groundwater, come from? Okay, come to this groundwater, and that's what some of my colleagues at Columbia University, who are more geochemical researchers and earth sciences researchers, they have been investigating. And as you can see, these are all the rivers in that region, in this Asian part. This is South Asia, and this is the Southeast Asia. And this is the part we are talking about. This is actually, there are two major rivers that delta is in this here. And then you can see that there's another Mekong River here in Cambodia and Vietnam, and here is Red River. So most of this area actually turned out to have some arsenic problem. But the underneath, when they have looked at it, so these are the 5 countries they have surveyed many of those wells that get underground water. And these pictures show the concentration of arsenic on this axis, and on the vertical axis is actually depth. And this is the, starting from here, this is the depth. As you can see, in at least these 2 countries, that the person I mentioned, the area I'm talking about, West Bengal, India, and Bangladesh, as you can see, there is a negative correlations with regards to the arsenic and depth underneath the ground. The deeper you can go, you can get less arsenic-free water. The shallower the wells you can get water from, more likely that you will get arsenic. That is not true for Cambodia or Vietnam, or even to less extent is in Nepal. So the point is that while my colleagues are trying to understand where and how this arsenic come from, it is difficult to address, and it's not easy to understand how it came. But I'll come to that later when I talk about the mitigation of the problem. This phenomena has some relevance. But
is that because those wells are deep, or because there are no points when it gets deeper?
That's a good question. So I do not know exactly whether their sample happened to, all of their wells they sample here happen to be here, or this only shows the wells that has arsenic concentration. So I don't know whether they're better. But the point is a good point. I will ask my colleague. This is Dr. Lex Van Geen at Columbia. He has been doing this investigation and given me these slides. So what are the problems of this arsenic? What is wrong with arsenic being in the drinking water? It's unfortunately, as I said, based on the extensive number of studies conducted in Taiwan and South America, particularly Chile, we know that chronic consumption of arsenic is actually related. there's a heading here is early and intermediate in these health effects, and these are the late health effects. So as you can see, the variety of health conditions have been associated with arsenic exposure, but most of the deaths that happen from chronic arsenic exposure actually happen from these conditions: cancers of skin, bladder, lung, and liver and kidney, and also some of these stroke and other cardiovascular events. That happened actually in Taiwan and South America mostly. That's what we know. In poorer country, in South Asia, which is even poorer, actually many of those conditions, even those do not kill people in some of the developed countries, but in poorer countries, even some of those non-cancer conditions actually can kill people because of the lack of appropriate health care in that country. So anyway, so this is what we know, mostly based on, at least we knew 10 years ago when I started working in this area, based on studies in South America and in Taiwan. And we wanted to know what's the situation in the southern Asia that I mentioned to you. The health effects of arsenic, I don't know whether you can read them. Here, I listed here all the carcinogens in the drinking water, and arsenic is clearly the most important carcinogen in drinking water. And if you can see the 50 microgram per liter, which is allowed by that part of the world in India and Bangladesh, even at that concentration, the risk of cancer is about 1,500 cancer for 100,000. Okay? And if you look at this number, it's often not appreciated, but this is actually the same number of deaths that happen, cancer cases that can happen from tobacco use. So even at what is legal in that part of the world, arsenic concentration can lead to the number of cancers that actually tobacco use can lead to, if the same. So it is often, it's not appreciated that arsenic can lead to that many number of cancers or other diseases, and obviously the deaths happening from those. So with that knowledge, I will mention now next few slides about what research we have done. So in 1999, when I was at Columbia University, me and my colleagues, we started this work specifically in Bangladesh, and we established several studies since then, but this is the main study that I will mention. We have chosen one study area in that part of the world, and we have tested every single wells, that hand-pumped wells I have shown you in that area, and there are about 6,000 of them. And these colors show, the darker color shows high arsenic concentration, lighter color shows low arsenic concentration. And these 6,000 wells serves about 70,000 people. And over the last 10 years, we have been actually doing a lot of epidemiologic research studies to see what are the characteristics of those populations, what exposure actually leads to what disease risk over what period of time, and what can we do to prevent those health problems. That's what we have been investigating. And I'll share a little bit of some of the results that we have seen there. This is a typical family of this population that we have been studying, and you can see that there are several children. This is the wife of the gentleman. This is the gentleman, and everybody, like those families, they drink water from one well, and they all get exposed to arsenic. And the classical symptoms that happen from this arsenic exposure is those skin conditions. That happens in few years of exposure. And if they are not treated, if they continue to get exposed, subsequently this squamous and basal cell cancer of skin that happens, that's one of the examples. There are many other cancers happen, but this is the external cancer that we can see clearly. And this is the wife of that family. And the gentleman himself had a more advanced cancer and had to have the amputation of part of the hand done for the squamous cell cancer of the skin. So you can see that this whole family typically, who get diseased from this arsenic exposure if they have been drinking water, contaminated water for sufficient period of time. And you can imagine that how, and this is quite given the prevalence of this, and these conditions of this, there are many other social and ethical issues related to this condition. These people get marginalized, and then for many, I'm not going to go into details, but you can think of many ethical and social issues could be related to that, and that's another area of investigation some of my colleagues are doing. But I just wanted to give a sense of what it is. In terms of when the arsenic came to groundwater, my geochemistry and earth science colleagues, they are trying to understand that. But even from our medical side, we are trying to see whether our studies can shed some light towards that. So what we are doing, this is the pathognomonic conditions. No other conditions will lead to exactly this characteristic, this kind of lesions than arsenic. So this is so from our medical research point of view, this is a condition. If we studied, say, arsenic causes lung cancer, if we studied lung cancer, some of those lung cancer could be due to arsenic, some could be tobacco, some could be genetics. It's a combination. It's hard to know which is what. So if we study this condition as a phenotype, nothing else can cause the other exposure. So we can understand the pathology, the risk profile very accurately by studying this. So that's what we did. And you have a question, Mark?
No, so it's pathognomonic of the arsenic.
Arsenic exposure.
And it's also the earliest symptom or manifestation?
Exactly. So this particular skin condition. Of course, these cancers happen on subsequent to this, but these are early, yes. Right. And that's the point of intervention if we want to do. And I'm going to come back to that. That's a good point.
Are those the children of the two?
These are the children. So this is a child, this is a child in that family. This is the wife, this is the husband. Okay. So now I will not go into today, but there is a genetic component also. Not every family who are exposed to the same level of arsenic get the same phenomenon. Only someone gets disease, someone doesn't. But that's another area of my research interest, where we try to understand some people are genetically more susceptible to the carcinogenic effect of arsenic than others. So that's another area. But what we did now, then in our study, we went in 1999. Only 1-2 years ago. Before then, the problem was discovered there. So, but these people have been drinking this water since 1970s or 80s. So we need to know, to help our geochemistry colleagues, when did this problem happen? What we did in our own interest, we measured, say, this population, about 20,000 people, their exposure to arsenic by taking a sample of water they drink, taking a sample of urine, taking a sample of blood, and also we constructed a lifetime exposure index based on their history of exposure for the current well and past well. And as you can see, and we used, those skin lesion measure as a phenotype. And as you can see, no matter what exposure measure we use, you see a very, very similar dose-response relationship. With higher the dose of those exposure and with higher the risk of this is the risk estimates, okay, risk of those skin lesions. So what it tells you, this urinary arsenic and blood arsenic, these are very transient measure of exposure, meaning 80-90% of the arsenic that someone consumes, in a few days they get rid of everything. And blood is even transient. Most of the arsenic do not stay in blood. They go to either excreted from the urine, and the remaining leftover goes into the tissues and binds there. Okay, but you can see even the current exposure. That's right at that moment what urine sample and the blood we took, that is related to their subsequent risk of, over several years, this risk of skin lesions, which takes at least several years to develop. But the point is, even this transient measure and this long-term measure gives the same dose-response relationship, meaning that these measures actually are strongly correlated with this long-term measure, and essentially this has been the typical of their exposure over the long period. Meaning, and they haven't, until we went and took these samples, they were not aware of this problem, and never that arsenic, probably they have been exposed to arsenic. So they have been, whatever that their arsenic we see in urine probably has been there for 5, 10, whatever longer of years they have been exposed to. And we see this phenomena. This is for skin lesions, which takes about several years to develop. And now we see the same phenomena in relation to mortality, cancer development, which takes decades to develop. So the point is, these individuals, before we went 1999, they must have been exposed to this for several decades, 2 to 3 decades, because otherwise why would a current transient measure and the lifelong measure would give the same dose-response relationship for cancer or mortality? Okay, so that's what also tells us indirectly. And of course, our geochemistry colleagues are doing many other fancy experiments. Some of those that they can even date the groundwater by studying different types of radioisotopes, and some of the radioisotopes, they can predate, whether depending on their constant decay of a half-life, they can actually measure the age of the water in a given point, and they also conclude that yes, it has been at least prior to this groundwater, they have started to use in 1970s. It has been before that. So whatever the cause, whatever the mechanism by which arsenic became and leached to groundwater, it had happened many decades ago before they started using that. So the point is that, unfortunately, when this installation of those mass wells, there are 10 million wells in that part of the world, if they tested, even a few wells before they tested it, before they installed them, this could have been detected. But so that's a major ethical issue and legal issue. But I'm not going to go into that. But that's given this theme of this talk, I want to mention that. So there are actually some of these there are companies, UNICEF and British Geological Survey, who have done most of this campaign for installation of wells. There have been litigation against them. They of course meant well, and they were successful. The infant mortality because of that switch of water has gone down, less than half. So at the end, probably this have saved more life and life years. If you think of the number of children is being saved, than the harm that's being done. But nevertheless, if some careful testing at the beginning, even at the time of 1970s or 80s when they installed, could have prevented this mass poisoning event. So I wanted to switch gear in terms towards a little bit of health problem. So in Chile. This is an example of my colleague who has done a study in Chile. So there, the exposure, people have been exposed to this arsenic through drinking water, in millions of people prior to 1950s and 60s. And then after that, the problem, water have been, they have been given safe water. So, but up until now, there's 2 points I wanted to mention. One is, once you get chronically exposed for 10, 20 years, their lifetime risk of getting arsenic-related cancer remains high, even if you drink arsenic-free water for the rest of your life. So that's an unfortunate phenomenon, but that's true. And we have learned that from Chile and other countries. And so that's one point. And I'm going to come to another point, interesting characteristics. But here, I wanted to draw your attention that what we are anticipating now happening in South Asia is similar. So they have put here, these shaded bars are the deaths from cancer, and this white dot is the deaths from cardiovascular diseases. Sorry, actually the opposite. So the shaded bar is cardiovascular diseases, lung cancer, this myocardial infarction, and this lung cancer is these dots here, and bladder cancer. Okay, bladder cancer is these vertical ones. So the point is, right after the exposure was removed, even many years, 2 to 3 decades after that, the cancer mortality has still remained high in Chile. That's one point. I'm mistaken. The cardiovascular mortality. But over time, the cardiovascular mortality gone down, and the cancer started to appear, and that are the predominant cause of the death mortality in those exposed population now. So epidemiologically, what we are trying to understand that in people in Bangladesh and India, we will see a bulk of these cardiovascular diseases in the next few years or in a decade, and then over time we will see many a cancer epidemic that these people will face, even if these people the water problem is solved tomorrow. So that is an unfortunate phenomena we are going to face in that part of the world based on what we see in. You have a question?
So you think that the lung cancer, the biggest risk for that is the arsenic as opposed to smoking?
In this population, in the general population, yes, of course, tobacco is is bigger population in population. But if people are exposed to arsenic, then I do not know it's the bigger problem, or at least equally big. But unfortunately, on top of that, tobacco smoking and arsenic exposure, they have a synergistic effect on top of that. So individuals who smoke and are exposed, their risk of lung cancer is even higher than that. But my answer would be probably yes, depending on the dose of exposure. But if someone gets at this level of exposure, their risk of lung cancer would be maybe even higher than lung cancer, tobacco smoking. That's my sense. But we'll know that for sure later.
Did they distinguish between the different types of lung cancers, and some of them are?
Excellent question. Yes. So there are, like tobacco. Like tobacco has certain type of lung cancer tobacco causes, and arsenic also has something similar. So it's mostly squamous and less of an adenocarcinomas of lung cancer that are caused by arsenic and tobacco. We used to know that is mostly squamous, and now we see adeno also, and less of the small cell. Yeah. Other questions? All right. So this gives a feeling to us what we will be investigating. And so far we have followed up 20,000 people, assessed their exposure at baseline, and followed their mortality for the last almost 6.5 years. Based on that, we see that, as you can see, this is the all-cause mortality here, and the rate in this vertical axis, and the horizontal axis is the dose of arsenic exposure at baseline. As we can see that with a higher dose of exposure at baseline, obviously, since they participated in the study, we provided them arsenic-free water. I'll talk about that in a second. But even their baseline exposure, which reflects their past exposure, is highly predictive of their mortality, both from all-cause mortality and even stronger, more strongly predictable is the cardiovascular mortality, as consistent with what they have seen in Chile. Okay, and we can see that. And the point, another unfortunate point is that even the dose range is 15 to 60, which is essentially close to the legal limit, 50 microgram per liter. So even at that dose range, or right a little bit more than that, the risk remains high. These particular numbers are not statistically significant because of the small number, but there is a trend that even dose range that are considered legal in that part of the world actually is related to the excess mortality due to arsenic exposure. So this is what we are unfortunately observing there over the last 6 years of follow-up. And consistent with, again, sorry, it doesn't show clearly, but this is what in a measure we use in epidemiology called population attributable proportion. So in other words, what proportion of the disease or an endpoint in relation to the exposure is actually caused by the exposure itself. In other words, if not everybody who smokes get lung cancer. So if 100 people smokes and 10 of them develop lung cancer, how many of those 10 actually happen due to smoking? And how many of those 10 actually happen due to other causes? So that is called as the attributable proportion. So this one you can show. So the proportion of all mortality happening in this population who are exposed to 50 microgram per liter or more arsenic, which is about, as you remember the number, about 40 million people. So close to 1/4, if not 1/4, of the deaths that happening actually can be attributed to arsenic. And if you take cardiovascular mortality, this proportion is a bit higher. So almost 1/3 of the deaths that happening in this population, these 40 million people who are exposed to 50 microgram per liter, that could be attributed to arsenic itself. So another way to say it, if arsenic exposure didn't happen, these 30% of the death in this population probably could have been prevented. That's another interpretation of that. So this has some major interpretation, and this finding actually is being now published in Lancet. But so that's what we see there in Bangladesh. We don't have enough number of cancer now, but based on the number of cancer we detected so far, as you can see from Chile, the numbers only can go rise even if the exposure is removed. And we made a prediction of the total cancer burden only from 3 cancers here, lung, liver, and bladder, in this population, given the exposure they have and given the effect that they have achieved so far and what we can predict based on another country. And you can see the white part of the bar shows the number of cancers that are happening now in this population, and the red part, the darker part, shows the number of excess cancer that will happen. So as you can see, of the total cancer deaths this population will face over time, almost half of those cancers will be happening, unfortunately, because of their exposure. I'm saying past exposure, assuming that the exposure will be removed, but because of this, so it's essentially doubling the number of cancer deaths in this population, given the exposure they have already accumulated. So clearly, this is going to be a major problem in this population. And I want to give 1 or 2 examples of, unfortunately, a little bit of even darker side of this. One is my colleagues who are neurotoxicologists and psychologists, they are investigating the effect of arsenic on cognitive development in children. Arsenic, like many other, arsenic actually crosses the placental barrier. So if mother get exposed during pregnancy, the children, the unborn fetus get exposed. And obviously, if the fetus once is born and they drink arsenic water, they get also exposed. And this is a study they did among the 6-year-old children. And as you can see, the exposure to arsenic exposure. This lighter the color, higher the dose of exposure, and the left side, the darker is at the low dose. For their measures of IQ are positively, negatively correlated with the arsenic exposure. So what is, unfortunately, and this has been replicated now. Then this was the 6-year-old. Then they did on an 8-year-old. Then they did a 10-year-old. It's consistent. It's published. I'm just showing you one figure. So unfortunately, even adjusting for all other determinant SES factors, this exposure alone could be detrimental to their cognitive development of these children. So this population, forget about those cancer and other late effects that's going to happen later. Right now, this generation of children are being affected negatively because of this exposure, unfortunately. So this gives another dimension to that. And the final dimension I want to mention, again, as a green picture, is, again, this comes from Chile. Again, this study was published recently by my colleague, Alan Smith. So what they did, remember I mentioned to you in Chile, the exposure to arsenic happened in around 1950s or late 50s. And in 60s, they started to give arsenic-free water in the whole country of Chile and removed this exposure over the next 10, 20 years. And it only happened 2 or 3 provinces of Antofagasta and some couple of other provinces in Chile. So they took the birth cohort, children that were born during the time of exposure. Actually, sorry, I'm sorry. I told you the number a little bit. I couldn't see it here clearly, so I told it a little bit differently. So this is the period when the actual exposure was there, and this is the pre-exposure, and this is the rest of the Chile. So these are the children, dark color, who were born at the time of the height of the exposure in Chile. These are the children who were born before that arsenic problem, and these are the remaining part of the Chile. And these are the vertical axis is the standardized mortality ratio, which is the measure of relative risk of dying from respiratory diseases, lung cancer and other chronic respiratory illnesses, in their adult life when they're 40 or 50. So the point is that those children who were exposed to arsenic when they were born or in early life years, their risk of dying from these diseases during their adulthood is higher than those children who were born before and got exposed during their teen or late adult years, and obviously much higher compared to those who were never exposed to arsenic in the other part of the Chile. So this even tells that the critical effect of some of this cancer and other disease that we are seeing, the critical window is early life. So those who are getting exposed during their early life to arsenic through drinking water, their risk of these respiratory illnesses during their adult years would be high, even if higher than those who are getting exposed at their adult life now. Yeah.
As you know, I missed the earlier slides. I apologize. Yeah. But is this through a mechanism of innate immunity, doctor, would you say? Because there's work done by Hamilton at Dartmouth.
Exactly. Yes.
So what is your hypothesis?
Yeah, so Josh Hamilton is one of the one who have looked at some of those from Dartmouth. But yeah, the exact mechanism is yet to be known, but arsenic causes cancer many different ways: oxidative stress, DNA repair damage, and disturbing the immune status. So that is one of the hypotheses. It has been put forward, and to explain this early life exposure, some of those early life, programming, development, DNA methylation status, epigenetics. Those are now some of the biological mechanisms now being considered that could be related to this early life exposure and their effect on long term. So it's a biological aspect that is being investigated, and that immunity could be one of the roles, but we don't know for sure.
The lung cancer model,
yeah.
Would you think that it would be through endocrine disruptor? I mean, as you stated, there are multiple factors, but in terms of lung cancer and the work you've done with TB, what are you seeing?
I wouldn't be able to answer that question. I don't know the answer for that particular mechanism, but it might as well be feasible. Anyway, so that's what we have in terms of health effects. So we can estimate what are the possible future health burden this population in this part of the world are going to face, or in the next decades or so. So obviously, what can be done or should be done. So the problem is predominantly done, tackled. The drinking water solution is predominantly tackled by our geochemistry, earth science colleagues, and the health policy people. And so there are obvious simple thing is that that you test all the wells, find out which one has arsenic, which one doesn't, and then try to identify the wells that are safe and try to have individuals drink from those existing safe wells, and then those wells that has the arsenic concentration, try to use filter or some other way to remove the exposure. Those who do not have access to safe well in the near area, then we have, think of the providing alternative water sources. There are many propositions, and some of them are expensive and it's very difficult to do, and it's not going to happen unfortunately in the near future. And then, as I mentioned, since the health effects persist even after removal of exposure, just providing arsenic-free water, which is a must. Beyond that, we also have to think of what other way we can prevent the health effects those who have been critically exposed. And I'm going to mention, and obviously, the integral part of all of this is health education and rehabilitation. And I'm going to touch a little bit of that, of what we have been doing from our own perspective in that study area that we are studying, and what lessons can be learned from them. So, as I just to make a point, it's a disciplinary problem requiring multidisciplinary and a multi-pronged approach to tackle it, and that is being now attempted by the government and international community. From our own side, I showed this slide you before, and I mentioned that this, I think the point that at least in these two countries, India and Bangladesh, there is a negative correlation between the depth of the well and the arsenic concentrations. And so at least what it shows, at least in this tube area, if someone can go and put a deeper well, chances are that they might get arsenic-free water. So that's one of the things that people, at least in some part of the country where people, they are aware of the problem, they can do this. So unfortunately, it's as you Mark just mentioned, it's almost 300 meter, beyond 2 to 300 meter. If you go down, you can get arsenic-free water, but it comes at a cost. So it's much cheaper to put a well, shallow well, to put 300 meter. It costs almost $1,000 equivalent. So which is a lot of money for the people in Bangladesh or in India. But that is one solution. So if you can go, at least in this part of the world, if you can go deeper, you can get arsenic-free water. The other is because there is a little correlation with depth, and also I don't show it here, but my colleagues, earth science colleagues, have also discovered that with the soil characteristics and other earth science characteristics that they can correlate arsenic with. So with the help of that, they actually have made some prediction tools by which you can predict that, okay, given this is the soil characteristics, given the depth of the aquifer where you can get safe water, they can give some idea how far and where, which location, if someone wants to drill a well to get drinking water, what they can do. So there are some interesting work my colleagues are doing, and some of them are being turned out to be useful. But to what extent it could be useful at a national level, that's a different ballgame. But that's what they're doing. And obviously, in our own area, as I mentioned to you, we have the population, the 70,000 people that we have been studying, we provide them, a free medical healthcare, primary healthcare, because they cannot afford to, get healthcare access. So our physicians see these participants at free of cost. Partly because this is a service we give to them, and partly also because to help our research. Because if we don't, this is the only way we can capture what diseases they are developing, and all these studies that we are doing. This is because we are the one who are detecting the health conditions and then studying them. We cannot rely on some other registry to give us a count of how many of these individuals will actually have developed lung cancer. We have to detect that. So that's why we are doing that here. And with help of our social science colleagues, again, we have a number of individuals from the SIPA at Columbia University who are working with us too, and they have designed a more health education campaign that is more of using this culturally acceptable methods there, again to to make the people aware of the problem and also giving them information about the parameter I mentioned, what are the safe wells and where should they drink water from, what are the consequences. Some of this stuff we are doing. And I will show you in some of the example what happened. So we have, this is our data from our individuals. We have been investigating 6 years. So we measured their urinary arsenic, as I mentioned to you, at the baseline, and we also measuring urinary arsenic during a repeated follow-up period. Mark, you have a question?
No.
Okay. So as you can, so based on our health education and intervention information that we have given, so we have given them, so remember we measured every single arsenic concentration of every single well in that area. So we know exactly which one is good, which is drinkable, which is not drinkable. So we gave those information to them. So told them, okay, your well may have arsenic, but if you can walk, at 100 meters, you can get arsenic-free water. So that's the information we gave. Then we gave them health education. And this is a documentation of whether that worked or not. And as you can see, we have been interviewing them repeatedly. So these are the you have a question? Sorry. Okay, so these are the individual light bar are the individuals who have said that they have switched to a safer well based on our health education campaign. These are the dark green and light green individuals who didn't switch. And if you look at their urinary arsenic measure, if you take the difference between follow-up measure minus the baseline measure, as you can see, there's a big difference on the urinary arsenic between baseline and that follow-up, and the drop happened more for those who switched to the safer well, who said, versus those who didn't switch to the well. So, so we are trying to make, whatever the effort we are putting, it is making some difference in this population over time. No matter what they drink water from, their urinary arsenic will reflect that, as I mentioned to you. So even if, this is something we have been doing, and again, it seems to be working, and we can even document that in terms of actual. We have been tracking their new onset of the skin conditions, and as you can see, by setting, these are the individuals who used as a reference group, and these are the individuals who said that whose urinary arsenic actually gone to the opposite direction, these who actually going to the right direction. As you can see, there is individuals who have switched to, reduce their urinary arsenic, there is risk of the skin lesion is also going down. So again, whatever I showed before is actually being documented by showing that their actual diseases are going down by our intervention. Just wanted to show this again. This is not enough. Obviously, as I mentioned to you, even after all these individuals who have accumulated these years of exposure, decades of exposure, their lifetime risk of cancer and other diseases, unfortunately, is high. And what else can be done beyond all this? And there obviously comes some of the other avenues. I'll give you a couple of examples. A lot of studies we are doing now. So one example, for example, we found that this dietary intake of these certain antioxidant vitamins and B vitamins are associated with a negative risk, reduced risk of this arsenic-induced lesions and skin cancer. This is the risk. So as you can see, with the higher intake, this is the low intake, the high intake. This is the lowest quintile is highest quintile. So with higher intake, the risk of these diseases goes down. So, and we have done many other supporting investigations at molecular level, at clinical level, and we have come up with enough data to suggest that. Someone asked a question about the mechanism of getting cancer. One of the mechanisms that arsenic causes this cancer is through oxidative stress-mediated DNA damage, and then that through the cancer. So we have now since got another NIH grant to do a large-scale chemoprevention trial to see whether supplementation with vitamin E and selenium can indeed prevent the risk of this cancer. And what we did, we took 7,000 patients who have those arsenical skin lesions, as Mark mentioned, who are early, early sign of this individuals who are at higher risk of cancer. And we are following them over time by giving a 5-year intervention by those vitamin E and selenium to see can we reduce their risk of skin cancer by doing that. And the reason we do that, these are quite less expensive and theoretically mass intervention by selenium and vitamin E, either by individual pill or fortifying salt, the way iodine is fortified in the salt. There are some way of doing that. That's why we chose those agents as opposed to other expensive agents, which can also prevent these health effects. But in that setting, it would not be feasible in the large scale. So we are investigating that. You have a question? Yeah.
Yeah, I just wondered, you had quintiles of amount of vitamins at the high end. Was that just an average recommended daily intake? These aren't hyperdose vitamins.
No, it's not hyper. In general, these individuals are deficient. Yes. I must say. So I don't. So it may vary on individual. Not everyone has the same recommended level, but in general, these are just quintile, and I would sense that most of those quintile will not be much higher than what is recommended because of their deficiency. Yeah. Yeah.
I wanted to ask, when we're looking at the molecular toxicology, and
Yeah.
now you're introducing an intervention,
Yes.
we know that small is the new big. And on many of the studies, when we look at heat maps, it's not only what you are adding into the diet, but what gets upregulated by the arsenic and then the combination of the vitamin E and the selenium. So can you comment first, what's your methodology? Are there any, toxicological interventions that you've seen that come from your administration of these vitamins?
Yeah, so I'm not presenting here, but we have published, and even at many different levels. For example, so one is we measured their dietary intake based on food frequency questionnaire. What do they to consume, and correlated with exposure. That's one thing. Then we measured their blood levels of corresponding things. So we did look at those based on food frequency questionnaire. We looked at blood levels of vitamin E and selenium and correlated that with their actual clinical, and we see the same thing. Then, and we also did in vitro experiments at a molecular level. What you're trying to get is that, so we took samples of blood from these individuals who were exposed to arsenic and have measured their gene expression profile by doing the gene chips. So that's a little bit more heavy molecular, but since you asked, and we see, of course, there's certain sets of genes that go up-regulated, certain goes down-regulated, and a predominantly set of oxidative stress-related genes that you expect to go up-regulated as in response to a compensatory mechanism. We see that. And some of those other DNA repair-related genes, it goes down-regulated. So it does fit with our hypothesis. And we went even further, just to see, since you were interested, we did even a small pilot trial. So we looked at the gene expression profile before you intervene with these interventions, and we measured the same gene expression profiles of the same individuals after 6 months of intervention by vitamin E and selenium. And you can see the genes that goes up-regulated, by intervening, you can down-regulate them after 6 months. So it goes exactly the opposite direction. So we have done enough to convince ourselves that it is worth doing a large-scale trial, and that's where we have, after doing all this, we have started this, and that's it. So this trial is now undergoing, we'll soon know, it's almost, our 5 year is gone, it's the second 5 year is being done to complete the trial, and we'll know the results or whether it works. The other point, the last point I want to mention is, again, I'm not going to detail, just to point, in addition to the vitamin E and selenium, another type of micronutrient that might be useful in this particular set is the folate, because folic acid actually helps excretion of arsenic from the body. So it doesn't help in the way the vitamin E and selenium does. Once you get rid of the arsenic exposure, it doesn't help. But when you are being exposed to arsenic, folic acid intake can promote the excretion of the arsenic from the body. And that's one of the reasons we can see that, with the individuals with the high folate intake, their risk of arsenic-induced death in the white bar is low, but individual with low folate intake, their effect is what risk of mortality, cardiovascular mortality from arsenic is high. And again, we have some molecular results related to that aspect also, and doing also a separate trial outside that one I mentioned to see whether folic acid can be preventable, can be used to prevent some of this toxicity from arsenic, at least when they're getting exposed. And this is a smaller trial, and I'm just going to mention that. So, so these are some examples, some of the multi-pronged approach we are trying to do. We are trying to promote their the removal of arsenic exposure by providing health education. We're giving them actually some, those who cannot do that, we're actually giving arsenic removal filter and other way, and we are giving this biomedical support, and we are trying this nutritional and pharmacological intervention to find out in a way we can reduce their risk beyond those removal of exposure. So that's what we have been trying. And just wanted to mention, we have just to, actually it's not just me. We have a large team of investigators working together here, and this is a list of almost like 12 NIH grants that are being invested just to tackle this problem from the multiple area, and this is being done now in that particular study regions. So we are trying to understand as much as we can from the tragedy and try to learn what we can learn for prevention of health consequences in this population as well as other future situations. God forbid if we face this again. Okay, so I will end here, and if you have any questions, I will be happy to answer. Obviously, this comes with a very extensive amount of collaborations. We have almost 300 field staff in Bangladesh who have been working the last 10 years for the variety of these projects I mentioned. And we have individuals here in Bangladesh and here in US, and a large number of investigators who are working with us in these studies. Okay? Thank you.
Dr. Hassan's extraordinary paper is open for discussion. Yes, please.
I was curious what the theories on how the arsenic originally got to these locations. Was it just naturally had arsenic in the groundwater, or was there an incident that caused the arsenic?
Yeah, that's. I wish I could answer that question. What I hear from my earth science colleagues that it's not exactly known, but in this part of that part of the world, because of there are many different hypotheses. One hypothesis is that arsenic is there, it's high, but it's mainly in the soil and rocks. It was not in the. It's normally is not in the drinking water. It hasn't been historically for say hundreds of years ago, but over repeated flooding in that area, that's one of the area you can know that it gets flooded because it's a delta. It gets flooded over time for every now and then. And one of the hypotheses is that due to repeated changes in water table up and down, some of those arsenic which were originally in the soil and rock got leached through some unknown chemical reaction into the water. And whatever is that, it happened, as I said, we have sufficient data to show that it happened before 1970s when they started to drink the water. It happened before that, but the exact mechanism I wouldn't be able to say. Is that?
Yeah, and that map you showed at the beginning, was that the percentage of arsenic in the groundwater, or just arsenic going through the soil in this area? You had a map with a very high concentration of arsenic.
That is in the those are the dots. So that was actually all the wells in the groundwater, actual water arsenic. It's in the wells, yes. That's a spatial distribution of the wells. That's what I showed here.
One of your slides in the middle of the presentation talked about the deaths attributable to the arsenic. And the number you showed on that slide was 20%. And so if the world exposure is in the order of 100 to 150 million people with attributable deaths of 20%, you're talking about
millions,
100 to 150,000 deaths a year in Bangladesh itself.
Yes.
If your small cohort can be extrapolated.
Yes.
Is that what people are thinking?
That's what we are thinking.
That's what you're thinking.
And I don't know whether obviously, again, if the same setting is applicable to everywhere, obviously the host factors make a big difference. Obviously, the same exposure, if it happens to U.S. or another country, which actually happening, we may not know, but many of the private wells, the countryside in U.S. that they drink water from actually have arsenic at the same level, some of them. But because of the host factor differences, nutritional, I didn't go into details. There are many, many modifiers of those risks. Many, starting from body weight, dietary intake of nutritional factors, education, health, the many genetics, there are many factors that modifies those risks. So obviously it won't be exactly same, but in that part of the world, we are confident that that's the level of burden they are facing.
It brings to mind, the bad outcomes from good intentions.
Yes.
I mean, the intention of wanting to improve the water supply.
Yeah.
I think of a book that we wrote in the early 80s relating to the use of X-ray treatment to treat tonsil disease in the 30s and 40s in order to avoid the danger and risk of tonsillectomy. And there, 20 or 30 years later, you get thyroid and parathyroid cancers develop. Nobody anticipated those at the time of the original intervention. And here's a huge social, economic intervention to try to clean up the water supply, which results unexpectedly. Yes, I saw a hand. Linda.
How do they address the problem in Taiwan?
Yes, I think this answer is money. Let's face it. It's you can solve this problem. We estimated with our colleagues. It doesn't cost too much money. Actually, I think we made an estimate because this is a small country, that region. This is a small geographic area. There are 150 million people in the size of less than Iowa. So even the whole country, Iowa. So you can do the piped water system for the whole country. It will cost $60 million or $70 million. It's not too much money. So that can solve it. But obviously, it's not being done. Even that $60 million, they cannot, prioritize there for whatever reason. I don't understand. But that's okay. But that's what happened in Taiwan. That Taiwan has, over time, they became economically solvent. So when the problem they had, 60s, 50s, 60s, they were not as economically as solvent as it is. The moment they afforded to do it, they changed the water supply system. That's it. That's the solution. Of course, there is still those who got exposed in that generation, they're still dying from arsenic-related cancer. They are documenting that. But at least, those who were born after that 1970 in Taiwan, they will be fine.
Stacey and Javad.
And have there been any documented teratogenic or fetal effects from the arsenic, and has that changed?
Yeah, it's a good question. I don't know whether they have. Second part, I don't know, but the first part is true. Yes, and as you can see, arsenic crosses placental barrier, and it can cause cognitive development. So it does play a role, and that's why it has some. We haven't documented in large number whether there is any similar neurological deficit, cleft lip or something of those. We haven't seen that, but there are some hypotheses that may as well true, that we are not being able to study that in our setting, with a large number that we can detect it. But my colleagues believe that is true because that they see that this cognitive development, they believe that may as well be true. What we did, I didn't present that here. We published a study that we did it indirectly. So we looked at the effect of. We couldn't do that exactly, but we looked at the infant mortality, in our the children of our cohort, and we have seen that those mothers of children who were exposed to arsenic, the under 5 mortality for those children is higher than others. So obviously it's a constellation of many causes. Some of them could be teratogenic effect. We don't know, but I have a strong reason to believe that there may be something. Yeah.
I think I missed something here about the mechanism of this. You said it is in the rocks, and then as if you said that somebody tried to do some good, did bad, but is the mechanism of arsenic around the world is the same?
No, it's not the same.
So how did those things got there?
The good did, how arsenic became, mixed with groundwater, that's one thing.
Yeah.
That we do not know very well. What about some complex geochemical process, combination with water table change, flooding, climate change, whatever something happened. Right. That's one thing. But the fact that arsenic is there doesn't mean that we will get exposed to unless you go and drink that water. Right. So that's what the good thing, bad. So those individuals never drank that water. This has been there, not a problem. They're drinking surface water. But the fact that we, international community, promoted them, go back and go and drink those water. That's why caused that mass shifting of water. That has actually caused them to be exposed from that water because they started drinking from that. So if they didn't drink, that would have been fine.
But in Bangladesh, people must have been living there for centuries.
Yes.
And so all of a sudden, since 1970, this came out.
because only then they started drinking that underground water. Before then, nobody drank that water. The ponds, you know.
If it wasn't there before the 1970s. So let's get in the weeds on how we're going to ferret that out.
Yeah.
Cadmium.
So I wouldn't be able to answer that question directly. All of those 6,000 wells I showed, this well water has been measured through ICP-MS. So it gives multi-element. So it gives free, we wanted to get arsenic, but it gives me a list of all other elements, including cadmium, manganese, nickel, everything. We haven't systematically looked at all of those elements, but we have the capability to adjust for other elements because we have the data of all elements for the 6,000 wells if we want to. So cadmium never came to our, we looked at some of the others, manganese, which is also quite high in that part of the world. But cadmium, we didn't see that to be unusually high, then otherwise we would have noticed that by now, but we can look into that.
Good work, I'm sure you're aware about Hopkins by Thompson on cadmium levels in the lung.
Okay, I know it's carcinogens, definitely, but we haven't looked at it, but we can if we want to. Yeah.
Have people moved away from those areas once the arsenic problem
No, there's no place to move. So, no, they don't move. They just stay there, and they move for other reasons. If there is a general migration from rural to, urban area, but that's a different, unrelated to this. Because of this, they don't move. No, they don't have any place to move. So, in general, mass people, maybe rare situation they may.
I suppose the answer to this is no, but just to clarify, it's not manufacturing or any sort of man-made.
Yeah, there were some hypotheses in those. There are many hypotheses towards that. One company installed, I forgot, hundreds of thousands of electrical posts. Okay, electrical posts that had some metal, and people said, okay, maybe those posts, caused those. There are many different hypotheses have been tested. None of them have panned out to be up until now. Is the consensus from what I hear from my colleague? It's natural. So up until now, yeah.
But in the U.S., it comes from mining.
Possible, sure.
Arsenic.
Sure, in the U.S. it's yes, definitely.
Let me see if anybody else wants that. Oh, yes, please.
In some of the efforts that are made to provide cleaner water for people, is the standard that's being used the WHO standard, or are you using the standards within the countries themselves? There's a difference.
Yeah, that's a very important question. Actually, and I would give you the short answer is that, right now, it's WHO standard people are trying to maintain because if we found some filter, which is reasonably expensive. We can give it to individuals, but it lowers from 150 to 51. 51 doesn't meet the criteria for should we not give it? So the people at the end, so whatever they can, they are doing it. Lowering is the is what they're trying to do, even if it doesn't meet the actual absolute criteria. So that's what is happening now. In the long run, I'm sure when the nationwide some solution is given, that would be meeting all the criteria. But right now, everybody is doing whatever they can. Yeah.
Do you and your group stick by this concept that in discussing this matter, you're dealing with the largest mass poisoning in history?
I haven't explored seriously to find out why that.
Phrase
WHO used that, and I just quoted that, yes. And I'm not aware of anything, but I'm not sure. I never made an effort to validate that, whether that is the case. Yeah, or if you did, I don't know. But I would be happy to know if someone.
No other hands. I'm going to call on Maria. You get the last question.
I just want to know, when we look at these exposures, one of the best areas to measure is in fingernails, and I'm wondering, urine's kind of debated in this area. Why did you select that? And why
no. It's not select that. We collected nail hair from everybody, but it's just 10 times more expensive to analyze nail arsenic or hair arsenic as opposed to even if it's long term. So when we have analyzed 50,000 urine sample over 6. It's just much cheaper.
We're going to bring you back and hear more about this ongoing research.
Okay.
It's
I'd be happy to.
Fascinating.
Thank you. Thank you. you.